these records are already available. The limitations for our study were that there were insufficient numbers of cases for small and survivor subgroups and rare cancers. But generally, with now over 7,000 in our cohort, that's not a problem. Oops. Data sources. Strengths, these are person-based records that we can link back to our cohort files. Verified diagnoses. The data were standardized, comprehensive over many years, and directly related to medically necessary care because of the structure of our health system and the requirements of the Canada Health Act. We're also fortunate to have the detailed clinical information from charts, and in fact, from my interactions with researchers in this field around the world, we appear to be the only jurisdiction with both the detailed clinical and long-term care data that we need to comprehensively look at risks and outcomes for this group. There are some limitations in the administrative data. For example, in BC, we don't have provincially available emergency data, but generally we cover our bases. What we're missing is the experience of care, which is why we used qualitative methods to augment our quantitative assessment. As many of you who've worked with data linkage know, it's a cost-efficient means to address this type of question. The only way to answer this question really was to have a cohort and long follow-up. In BC, we've been fortunate to have legislative privacy policy and BC Cancer Agency mandate that enables this work to proceed. And in the